Hi, all of you. A very good evening to you all. Now, in this particular session, I'll be discussing a very recent question which many of you will be familiar with if you have written your 2023 NEET MDS exam. Okay, which was an application level question, definitely, and it was related to pancreatic cancer. Now, this is the question which says that a 49-year-old patient presented with symptoms of jaundice due to pancreatic cancer. Now, you all know that jaundice is very much related to your hepatic diseases or liver related diseases. Now, it is said that patient was having pancreatic cancer with symptoms of jaundice. They can give more symptoms. I'll tell you what they are. So, pancreatic cancer at the apex of the pancreas, it can obstruct which of the following anatomical structure? Which structure is it obstructing? This pancreatic cancer is obstructing which structure? Means to say that what is the cause of this jaundice? What is this pancreatic cancer is doing to create the symptom of jaundice, or what is it obstructing? Now, if you go into this, you will see that there are options given as, common bile duct, cystic duct, common hepatic duct, and bile duct as such. Now, it's very easy to say you that the answer is going to be your common bile duct. Okay, very easy to say that. But then, you might be not familiar with these terms, cystic duct, common hepatic duct. Bile duct is just a general term. So, but you have to understand what is basically your common hepatic duct. For that, you have to understand the structure, this particular structure, what happens. Okay, now I'll just give you a broad understanding. Okay, and I'll also explain to you the theory behind that. So what happens, please note one thing, very important thing which you might not be aware of. This particular, they're talking about what? Jaundice. Okay, so that means what? The bile acid and bile salts which contain what? Your bilirubin. Okay, so bilirubin is primarily causing the jaundice. So let's understand a little bit on what happens, how is this bile acids synthesized and how is it passed and what is its relation to pancreas. Okay, so please note, though it says bile and all those things, okay, don't think that gallbladder is the one which synthesizes it. Gallbladder actually stores it. Okay, it doesn't synthesize it. The liver, specifically the hepatocytes of your liver, is the one which synthesizes it. And there's a ductal system, okay, from the liver flowing outside the liver, joining the duct from your gallbladder, finally coming very close to your pancreas out here and draining into your intestine where the digestion happens, the purpose of your bile. Okay, so let's understand the theory behind that. I'll explain side by side. I'll also explain to you the image. Okay, so if you just see this, synthesis and drainage of bile. As I've told you, what happens first is synthesis of bile, then drainage within the liver. Okay, make it close. Okay, so then what happens is a drainage within the liver, as I've told you, then exiting the liver, coming out. And then what happens is, as I've told you, joining the gallbladder, so there forms the common bile duct and finally release into the intestine. Let's understand each step involved. As I've told you, the synthesis happens, okay, the synthesis happens in the hepatocytes, or it is happening by hepatocytes, okay, and this particular hepatocyte synthesizes it in between the hepatocytes. So just imagine this particular picture out there. There is hepatocytes there. In between the hepatocytes, there are canaliculi. So this bile acid is drained, or bile is drained into the canaliculi, which is between the hepatocytes. Now, what happens? Within the liver, it flows now. Okay, that is, this biliary canaliculi converge. Okay, they converge and they form two ducts. They converge from different hepatocyte, it converges and it forms two further ducts, that is right and left hepatic duct. So you can see here two ducts coming from two either side. So in between this there is hepatocytes. Just imagine these are canaliculi and there comes a line right and left hepatic duct. So this is hepatic within the liver. Okay, now what happens? It should exit the liver. So what happens is that right and left hepatic duct joins and it exits the liver. Okay, and it forms a common hepatic duct. So naturally right and left has to join to form a common, isn't it? So this is what is happening, right and left common. So now you're understanding the options better. Simply learning this common bile duct here, which is definitely closer to your pancreas, easiest way to learn it. But then yes, let's understand this. So maybe you'll get a question also related to this common hepatic duct. So by this, it exits the liver and now it goes into the gallbladder. So it exits the liver and it goes going close to the gallbladder. Now you see, cystic duct is coming from the gallbladder, common hepatic duct. You get another common duct, which is called common bile duct, because the bile is now basically what happens if there is no digestion taking place. You'll tell me why, what is the role of gallbladder here? If you don't need the bile for digestion, it goes into this cystic duct and gets stored. Whenever the need for digestion, it comes through the cystic duct, okay, and it just goes here. So initially the pathway is like this, then it goes like this, okay. Now if extra bile is needed, definitely at that time it is synthesized and comes. So there you get the common bile duct, and then you get, now it is very important, I'll show you the image. Yeah, this is the common bile duct, this is the pancreatic duct. I'll go into details of that. So this both join together and you get what is known as ampulla of Vater here. Okay, this ampulla of Vater, that is a combination of your common bile duct and pancreatic duct, drains into the intestine, digestion takes place. So this is a very basic understanding. So there is a common hepatic duct, okay, we said just now, which carries the bile to the gallbladder. Then formation of this common bile duct, okay, where the cystic duct from the gallbladder I showed you, which combines with this particular common hepatic duct, you get the common bile duct, and finally it releases to the intestine. As I've told you, the ampulla of Vater. Okay, I'll explain to the structure and later on, but this is the ampulla of Vater or Vater, ampulla of Vater. Now, yeah, this I'll come to that. Now, if you have a cancer here, okay, it's the simplest way to understand this question. If you have a cancer here of pancreas, now where is pancreas? This is pancreas, and if you have a cancer of the head of pancreas, it can obstruct this ampulla of Vater, okay, or to be very specific, it can obstruct. Now imagine it is here, it can obstruct the common bile duct, okay, it can obstruct the common bile duct, compression, mass, no, cancerous. So as a result, the bile will not flow into the intestine. What is going to happen? Bile contains what? Bilirubin, and as well as other substances, but definitely the more dangerous is your bilirubin. It goes into the circulation. What happens is jaundice, and this is how you get this problem. Okay, now we have solved the problem of the question. Okay, that is, which is a structure which is obstructed. It is common bile duct. Okay, now if you ask me, should I learn a little bit more? I would say yes. So let's come to the structure of pancreas. Okay, and I'm going to also give you some additional points related to this pancreatic cancer. Lots of signs and things which you have to learn. Not lots, a little bit. I'm not going into details of it. Only the key points I will be discussing. Okay, so let's come to the structure of pancreas now. Okay, three things good to know here. One is the basic anatomical structure. Second is names of some ductal system there, and as I've just shown you, ampulla of Vater to be specific. Okay, now basically your anatomical structure of pancreas has got head, body and tail. Okay, so head means it's the widest part of the pancreas, also known as apex. Okay, if you just see this particular image, okay, head is the widest part. This is where the most common cancers appear, head of the pancreas, also known as apex, and that is where you have seen the question, the cancer of the apex. So it will obstruct the common bile duct. Then you have got the narrow part, tail, and in between is body. Okay, there is no confusion, just to clear the confusion. So now what is body? So what is the tail? The narrowest part. Now, ductal systems, though I was saying you about the ductal system, there is accessory small duct which drains finally into the main duct, as well as there will be accessory ducts here. Okay, so finally draining into the main duct, and then all comes in, there's a main duct, and finally into the ampulla of Vater where the combination happens. Okay, so the main pancreatic duct and accessory pancreatic duct, it would have been very good if they kept it like that, but unfortunately for us, they put a name. The main pancreatic duct is called the duct of Warsack, okay, and the accessory pancreatic duct, they named it as duct of Santorini. Okay, good to know. At least the main pancreatic duct, duct of Wirsung. Okay, now the next thing to know is ampulla of Vater. I told you that it's where your main pancreatic duct joins your common bile duct, okay, and converge and enter into the duodenum finally. So that is all about your structure of pancreas. Now, a quick understanding of some points and some features of your cancer of your, or I would say your pancreatic cancer, some key points, especially I'll be discussing on the exocrine. Okay, I'll tell you what endocrine is. Okay, I'll come to that. Now here, for some points to note, I'm going to discuss about a little bit on etiology, pathology and clinical features. Now, etiology, as I've told you, I'll be discussing only the key points. Okay, I'll not go into any extra bit of details. So what is the greatest risk factor? Lots of risk factors are there. What is the greatest risk factor? They're saying that smoking followed by age. Now, if they ask you one option, what is the answer? Smoking. Okay, smoking is the most important risk factor and nothing else. Not fruit. Some people say that fruit eating causes pancreatic cancer. No, your Harrison very clearly says that it is not true. Okay, even diabetes and all comes later, much later. The greatest risk factor is your smoking. Now, what they're saying is besides the greatest risk factor, you also have chronic pancreatitis. Chronic pancreatitis, not acute. Please note, if at all in the option comes acute, it is not the correct one. The chronic pancreatitis is key. Diabetes mellitus, definitely it has to be, and very importantly, genetics. Genetics is very important. If the parents had, the children also have a very high chance of developing the cancer. Now, the gene which is involved here, the key gene, which, list of genes are there. Okay, I'll come to that later on, but then one gene they specifically say that it's very dangerous is this STK11 or LKB1. Okay, I know many of you will be thinking, I've seen this somewhere. Peutz-Jeghers syndrome, intestinal polyposis, finally ending up in cancers, including cancers of pancreas, please note. Okay, so this is basically, why did I include it here, is 132-fold increase in cancer if there's a mutation here, or if a person has got any issue with this particular gene. 132-fold increase in pancreatic cancers. Please note. Okay, now one more thing. Okay, what is this? If someone wants to know what is STK11, it is serine threonine kinase, which is same as, it's exactly the same gene, which is LKB1, which is liver kinase B1. And as I've told you, it's Peutz-Jeghers syndrome related. So that will be the basics on etiology. Greatest risk factor, I told you, it is smoking, followed by age. Then one gene you have to note here at this stage is STK11 or LKB1. Let's go into the next part. Now, pathology. As I've told you previously, the pancreatic cancer can be cancers of endocrine system or exocrine system. Both can happen. Exocrine means what? The ductal system, where the secretions of that particular gland is going into the circulation or the target area through a duct. Okay, there is a ductal system there. Whereas endocrine, so this is what endocrine, there is no ductal system. Typical example is your insulin as an endocrine function of pancreas. Whereas, as I've told you, pancreatic juice, which comes through the pancreatic ducts, we studied. So this is like your exocrine. I'm not going into discussions of endocrine neoplasm. Just want to say you there is two endocrine neoplasms you have to just note: insulinoma and gastrinoma. Insulinoma, insulin secreting cells. Gastrinoma, we studied when we studied about the hormones of GIT. I told you that there is gastrin. They are gastrin secreted by the pancreas. So if there's a tumor of that, it's called a gastrinoma. And there is another name which you might have come across: Zollinger-Ellison syndrome. Okay, Zollinger-Ellison syndrome. Okay, I'm not going to that part of it. Let's focus on the exocrine system. Now, very important, most common and the most deadliest of exocrine tumors. Please note, most common and most deadliest of exocrine tumors are, now this term is very important, pancreatic infiltrating, okay, infiltrating ductal adenocarcinoma. Okay, basically adeno means ductal system only. You have got adenocarcinoma of your salivary gland, adenocarcinoma of your gastric glands, all those. Similarly, pancreatic duct, so the ductal area, adenocarcinoma, it's just a complicated saying that it's adenocarcinoma, or I would say it's re-emphasizing it's a ductal system which is involved. And we saw if ductal system is involved, or more importantly, the head of pancreas involved. Now, head of pancreas is comparatively rare, okay, but then it happens, not very rare, but the most common and the most dangerous is the ductal adenocarcinoma, okay. And yeah, a few more things. If it is the most common, if it is the deadliest, we have to learn a little bit more. What is that? 4 genes are commonly mutated. Now, in the one gene which is very specific, very dangerous is your STK11. But then there are, the reason why I include, as I've told you, is the 132-fold increase. But now, this particular cancer, pancreatic infiltrating ductal adenocarcinoma, or adenocarcinoma of pancreas, to be simplified, 4 genes are mutated in specific, very familiar ones. And it's called a 4 horseman. Okay, if they ask you, 4 horsemen related to pancreatic cancer is, okay, just remember these names. Okay, some of you might be knowing this. We studied these genes when we discussed about the tumor suppressor genes, protoncogenes. I'm not going into details of that in general pathology. So 4 horsemen, KRAS, P16, okay, related to that is CDKN, okay, CDK, N2A, and then very common TP53. And one thing, I think this gene you have not come across. I'm not mentioning the details of it, just know the name, just get exposed to if it, in case it comes, okay. KRAS, P16, TP53, you know it, CDK, you know it, DP6C4, DP, you know DP, you know what is DP, MAD, okay, MAD, okay, DP, MADH4. So these 4 are genes. Now here, I want you to specifically focus on one gene, KRAS, okay, RAS, you know the RAS system, yeah, we studied in detail. This is the most common, okay. This is the most common where there is 100% cases of your adenocarcinoma, pancreatic infiltrating ductal adenocarcinoma, 100% cases you will see this KRAS, 100%. Okay, so that's why they'll ask you a question, which of the following gene is involved in your pancreatic adenocarcinoma in 100% cases, or the most common gene involved, it is KRAS. Good to know, isn't it? So that was about the pathology. Okay, now I'll come to the, finally the clinical features. Now you'll see me, oh my God. Okay, don't worry. Few things here. What is the classical presentation? We saw it in the question. Okay, I'll come to more details. Jaundice is, I would say, supplemental. I'll come to that. But yeah, jaundice is a very important presentation. Then few signs there. Okay, Courvoisier sign. I don't know how you pronounce it. Courvoisier sign, or okay, however you want. So Courvoisier sign, you have to know this. Then there is Virchow's node. Okay, Virchow's triad. What is that? Your clot formation. Okay, thrombus formation, endothelial injury, we studied, isn't it? So yeah, but this is different. It is Virchow's node which is related to here, and it is, all these are not very specific to pancreatic. I'll come to that. Jaundice definitely very specific, or not specific again, very important symptom. It's a common presentation when the pancreatic head is involved, head of pancreas. Please note this. And one more very funny story behind the Sister Mary Joseph node. Okay, Sister Mary Joseph node. Okay, so let's go one by one. What is a classical presentation? Abdominal pain, okay, with weight loss, with or without jaundice. This is a classical symptom. Abdominal pain. Exactly, if you want to know the location, it is mid-epigastric, above your navel, just above the navel, middle area, mid-epigastric region. Okay, there is this picture. Okay, exactly. Okay, I think this picture is, okay, this is your navel, just above this. Okay, you can have the pain, mid-epigastric pain, and typically it says boring like pain. Now, I don't know if our patients will say that, but definitely the English-speaking population says that a boring pain. Okay, boring like pain, I would say. Not very severe kind of pain. So that is all about your classical presentation. Now, as I've told you, your Courvoisier sign. Now, what happens here is a palpable non-tender gallbladder. Because of obstruction, you see, your flow of bile is obstructed. What will happen to your gallbladder? It will enlarge. But then there is no pain, non-tender, enlarged. I'll come to this, okay, which is hallmark of extra hepatic, outside the liver, bile obstruction. You understand now? The common bile duct is obstructed. Okay, we've discussed with different types of jaundice. So, a hallmark of extra hepatic bile obstruction due to cancers is called the Courvoisier sign. So basically, this is the gallbladder. Okay, you can see that it is enlarged. Okay, and you palpate it, you see very typically it is enlarged. So more towards the right side of your epigastric region. So pain is here. Gallbladder, this is non-tender, told you. So that was about your Courvoisier sign. Okay, let's go into the next one, which is Virchow's node or Troisier sign. Okay, basically it's an enlargement of left supraclavicular. So where is the clavicle? This is the clavicle. This is sternum. This is the clavicle. Supraclavicular. I'll show you the picture out there. Yeah, this. Okay, this is a little exaggerated. So above the clavicle, not exaggerated. You see this kind of in this patient, but yes, this is a little big. Supraclavicular. Now, so that is called a Virchow's node or Troisier sign. Okay, here it's a sign of metastatic cancer from the abdominal cancers or pelvic cancers. Abdominal, one is definitely your pancreatic or stomach or even your pelvic, that is your ovary, testicles, okay, areas. So that is, okay, as I've told you, it is not a general or, I'm sorry, it is not saying that it is very specific to your pancreatic, but just good to know the sign. So it's an enlargement of supraclavicular. Now, enlargement of your cervical nodes is more pointing towards what? Your head and neck cancer. Similarly, supraclavicular is more towards your particular. Now, isn't it your cervical nodes? Yeah, it comes under, but then okay, more towards your submandibular, sublingual lymph nodes is where you get your oral cancer spread. Okay. Anyway, so that is one thing. Then jaundice is a common presentation, as I've told you, in a head region. Okay, I'm not going into details of that right now. Let's close it. Now, finally, Sister Mary Joseph node. Now, basically, if you have heard of Mayo Clinic in USA, chain of clinics in USA, I think in different countries it is there. There was a major surgeon out there who is one of the founders. His name is some Mayo itself. Okay, some Mayo, I don't know, Thomas Mayo or something like that. So his assistant name is Sister Mary Joseph. So he was the one who found out this particular node, palpable nodule, bulging in the umbilicus, that is the navel region, this typical picture in the umbilicus, bulging nodule in the umbilicus, okay, which is typically saying that in that region there is a metastasis of malignant cancer from abdominal pelvis. Now, just to note, again, this is, you have supraclavicular, again abdomen pelvis. So that is Virchow's node. But then Sister Mary node is your umbilical region node, lymph nodes, okay, which is again the same reason, and it is more towards your peritoneal metastasis. Now, peritoneal means It's a lining cavity which encloses all your internal structures, including liver, your pancreas, everything. So it comes out. Okay, peritoneum, or I would say peritoneum is affected here. So that is what they're talking about. Sister Mary nodes. Is it okay? They can ask you, Sister Mary node is indicative of what? Peritoneal metastasis. Okay, so both of this Sister Mary node and Virchow's node is indicative of metastasis from the abdomen or pelvis cancer. But then the location, Virchow's node is supraclavicular, Sister Mary node is umbilicus. Okay, then as I've told you, there is the Courvoisier sign. Okay, which is again your gallbladder being palpated. Okay, so I think that by that we can end this particular session. Just to refresh the question, 49-year-old patient presented with the symptoms of jaundice due to pancreatic cancer. You know why pancreatic cancer head can obstruct your common bile duct. Okay, so that is the answer for this. So that is all about this particular question. Thank you so much and have a great day ahead.